Welcome back and thank you for staying with us. Now in our second hour, we'll be focusing on leukemia in children. And as a country, we do have various statistics that have been witnessed in various parts of the country, especially in major cities. According to the National Cancer Institute of Kenya, in their report back in 2021-2022, indicated that 70% of cancer cases are diagnosed at advanced stages, with 2 out of 3 persons succumbing to the disease. The institute further notes that every year, up to 3,200 new cancer cases among children are recorded. The institute further revealed that only 3 out of 10 children diagnosed with cancer annually in the country survive. Some of the leading counties with these particular cases are in the major cities like Nairobi, Kisumu, Machakos, and other parts of Nakuru, as well as other devolved units of Kiambu and Nyeri. And of course, joining us to talk to us about these issues that are being witnessed in the country and if the treatments that these kids are receiving in the country are adequate are none other than people who reside within this particular sector. Let me start off with Celine Kilanya, a pediatric oncology specialist nurse at the Kenyatta National Hospital. Celine, karibu sana.
Thank you so much.
Okay, next to Celine, we do have Dr. Napo Mugoma, an oncology medical officer at the Kenyatta National Hospital. Daktari, welcome. And then finally, we do have Dr. Bernice Mukuria, a pediatric hematologist. Am I saying correctly?
Hematologist.
Hematologist.
And oncologist.
Apologies for that.
Yes, okay.
Hematologist, and of course, she is a member of KESHO. Let me start with you, Celine. Given that you work at the Kenyatta National Hospital, how are we looking like as a country in terms of the latest statistics, if you have interacted with the latest statistics that we have in the country, especially when it comes to leukemia in children?
Yeah. Thank you for the question. So where I work in Kenyatta National Hospital, we deal with the children who have cancer, and specifically leukemia is actually a leading cause of cancer in children. And being a leading cause, we get to treat them, we get to care for them, and there are quite a number. And you'd find that like in a year, we have like 500 cases in Kenyatta National Hospital, new cases. So you can just get to divide that in like every month. So they're quite a number, and we can say that we are dealing with them, we're caring for these children, treating them every single day, and we do have good outcomes. So as a country, we are making very, very many strides. When you get to compare between now and 5 years ago, we're making many strides despite the fact that they're quite a number. Yes.
And Dr. Napo, you reside in the same facility. Do we have enough resources to cater for these children?
The National Insurance Fund caters for most of the treatment. As long as the treatment is available in the hospital, the National Insurance Health Fund is catering for the costs. Yeah, so most of the all the treatment is catered for, as long as it's available within the hospital, come from diagnosis to the chemotherapy drugs, the support medication, and the support therapy as well. When you're looking at the transfusions, the supportive medications, anything that is available within the hospital is catered by the fund. Yeah.
And Dr. Bernice, finally, we're talking about some of the cases that have been reported in this report of the National Cancer Institute in major cities. What does that say as opposed to in other parts of the country where these cases have not been majorly reported?
Okay. So we don't have very robust reporting systems as yet in place. So it wouldn't be surprising if we checked other counties and still found that there's a number of new leukemia cases in all the 47 counties essentially. So most of the data is coming from the facilities that actually treat childhood cancer. So in those major towns and cities. Yeah.
And Celine, we're talking about some of these cases that have been recorded here in the country, but in children, there are different forms of cancer. But why leukemia is mostly affecting our young ones?
Yeah, being a leading cause, when we get to deal with the childhood cancer, we usually say that because of course the research is still ongoing, but mostly it's genetic mutations which usually cause leukemias. We cannot attest it to a single cause which brings it about. So like why we as a country we have the acute myeloid leukemia and acute lymphoblastic leukemia, and you find that acute lymphoblastic leukemia is actually at a higher rate compared to acute myeloid leukemia, of which that is now what we have at the moment. Yeah, but when it comes to the causes, we just get to say that it's mainly genetic mutations which bring about the cancer in children.
Okay. And aside from leukemia, Dr. Napo, are there other forms of cancer that are affecting the children?
Yes, we have the leukemias and the solid tumors. Solid tumors, we're looking at different organs of the body, from your brain to your liver to your lungs to your bones. We're also looking at the kidneys, which is also the most common, following the brain tumors and solid tumors. Yeah.
And Dr. Bernice, we're talking about some of the genetic mutation Celine is talking about. Inherited childhood cancer account for 5 to 10% of such cases. Is this preventable, given that they are born with that particular condition?
Unfortunately, this is not preventable. Yeah, and it also presents a challenge with treatment because the underlying genetic condition also predisposes them to even other types of cancer. So treatment for them becomes a bit more challenging than a child who does not have the same genetic mutations, but some specific genetic mutations. So in terms of the causes of cancer, majority of cancer cases are as a result of unknown causes, right? So that 5 to 10% is as a result of predisposing genetic conditions. So these are syndromes that are known. Yeah, they're very rare. Things like Bloom syndrome, ataxia telangiectasia, they're very rare. But when they do occur in these children, then they predispose them to multiple types of cancer or malignancies. Yeah.
And Celine, what are some of the treatments that especially the Kenyatta National Hospital that you reside in do offer when it comes to cancer cases?
So to cancer cases, we have different cancer treatment modalities, one of them being chemotherapy. We also have surgery, and we also have radiotherapy. And of course, this depends on the type of cancer. Because when we're looking at leukemias, like what we're discussing today, the mainstay of treatment is chemotherapy. And when there is central nervous system involvement, because this is blood cancer, that's whereby we have to include also radiotherapy. But now for solid tumors, like Dr. Napo has just mentioned, we usually have chemotherapy, surgery, and radiotherapy.
And Dr. Napo, we know chemo, it's a little bit harsh, not just to the adults, but to children. So how can these children bear with chemo? What do you make it? How do you ensure that those kids do not even suffer further pain?
There's a lot of the supportive therapy that is given just surrounding the chemotherapy. So there's the hydration, good hydration of the patient. If you're anticipating any blood cells going down the cytopenias, you have transfusions, you have bone marrow promoters, which they boost your immunity. There's antibiotic care, antifungal care. A lot of supportive therapy goes around the chemotherapy. It's actually bigger than the chemotherapy itself. The supportive care.
Comment on that as well. And while you do that as well, chemo, as I said, is a little bit harsh on kids as opposed to adults. Aside from therapy, what else can be done to ensure, or which other forms can be used to ensure that this cancer is treated, especially among the children?
You mean non-chemotherapeutic ways of treating cancer?
Yes.
Unfortunately, chemotherapy is still a major part of treatment of malignancies or cancers, both in children and adults. Interestingly, children are more tolerant of the chemotherapy compared to adults. They actually get very high doses. We dose them by weight or body surface area, so it's very specific. You don't want to give them too much and cause unwanted reactions. You don't give them too little and not have the intended effect. Yeah, so they do take chemotherapy quite well, actually, compared to adults. In addition to the supportive measures that Dr. Napo has described, there's also nutrition, which is a key component of supporting these children as they're going through therapy. Like you said, these drugs are very toxic. They take a lot. They affect both the cancerous cells and the non-cancerous cells. So you want to make sure that you're boosting their nutrition, you're keeping them, well hydrated, transfused when they need blood support or blood product support, etc. So there's all that. Then there's also other non-medical aspects of treatment, things like play therapy. Play is very important to children, to their well-being and for them to thrive. So we try to incorporate that as well in the overall treatment of the child. We try and continue with school as much as possible. So we try try to have teachers who will take them through, age-appropriate learning for wherever they have reached in school. So the smaller ones will be coloring and doing their ABCs. The older ones will be doing a bit more complicated stuff, just to keep them, still feeling like they are still children and they're still able to do the things that other children are doing outside of the hospital. So there's all that.
Yeah, and which is very vital, especially when it comes to certain diseases such as cancer. A lot of stigmatization has been witnessed. So how do you handle such cases, Celine?
Yeah. So what we do, we try as much as possible to create awareness, because with lack of knowledge, you'll definitely expect that there'll be many myths and misconceptions in regards to cancer. And you'll find that even in our setup, we've actually found that quite a number of parents who are coming now with children who have been diagnosed with cancer, that their families even get to excommunicate them. They go like, it came from your family, it's witchcraft, and such type of cases. So what we usually do, we try as much as possible. We actually have a program which is ongoing for parent caregiver education, and we also try as much as possible to create awareness in churches, and we're working very, very closely with the spiritual leaders like the imams, the pastors and the priests, so that they can be able to create this awareness in order for them to be able to know that yes, cancer is it's something which is really, really big, but it's manageable. With early diagnosis, early treatment, we definitely expect to have better outcomes. So that is what we're doing now.
And Dr. Napo, still on the same, but on a different angle, is there enough awareness, especially for members of the public, so that they can go out and get tested? For us as Kenyans, until imekuwa mbaya, that is the time you'll find us in hospitals.
Strides have been made. So there's right now there's more awareness with continued programs that are running. So a lot of the patients or the community is aware that in case you notice this thing is persistent, a child is no longer playing well, a child has reduced in the activity, there's a persistent or not getting well illness, like there's a recurrent illness continuously, child has reduced in weight, there's a recurrent anemias, you're always in hospital. There's now more awareness, more in the community, even in the hospitals. There's more awareness with the public and the healthcare workers now to look out for these diseases. Yeah.
And Dr. Bernice, we're talking about when a parent or even a community here, a member, is diagnosed with cancer, it is a major issue, especially here in our country. So what are some of these myths that are being associated with cancer?
Some of the common myths are that a diagnosis of cancer means death. It's not always true. In fact, with early detection, as Celine has mentioned, we have very good outcomes, especially in children. So cancer does not always mean death. In terms of other myths, the biggest one, I think, has to do with death. The others that come with a diagnosis of cancer have to do with the cost. Yeah, so we know that families now start thinking, okay, what does this mean? Do I sell land? What do I do? But like Dr. Napo mentioned, especially in public facilities, NHIF does cover a lot of the cost of treatment. So that's for chemotherapy, for diagnostics as well. It does cover a lot of that. So there's a lot of hope, especially for childhood cancer, and that's the message that we need to put out there. But if your child is diagnosed with cancer, it does not mean that's the end for your child. There's treatment available, there's help available, and there's always hope that they can, surmount that and proceed with their lives as normal as possible. Yeah.
And Celine, I'm sure you have received parents who do not have this medical insurance. So for a normal parent who was unable to detect such a cancer in their child, so how much, given that they are watching you right now, how much are they expected to come with to your facility to ensure that their child receives enough care?
Okay. Thank you for that question. I will still echo the sentiments of my colleagues. We really want the public to take up NHIF because it really does cover a lot of the costs. So when it comes to the costings, in fact, later today we'll be having a webinar, which is in conjunction with Kenyatta National Hospital, University of Nairobi, with the NCCP, the National Cancer Control Program, which will be discussing more on the costs. So when it comes to let's say, a condition like leukemia. So we expect for the whole treatment to go to almost 280,000. That is chemotherapy, because they're supposed to receive chemotherapy for like 2.5 years maximum. There are those who might have relapses later, and what we keep on saying is that yes, there is hope, and we need to create more awareness to the public so that they can be able to identify these cases, these symptoms early enough. Because the thing with childhood cancers, you cannot be able, most of the time it gets to present as a normal, like any other illness, like malaria, like frequent infections. So for the public and also the healthcare providers to have a high index of suspicion towards this. So when it comes to leukemia, 280,000 for the whole treatment for like 2.5 years, and this depends on the type of cancer. When it comes to the solid tumors, it's different. It might go to up to 70,000, and that is just chemotherapy. We have radiotherapy at Kenyatta National Hospital. We usually charge it at 3,600 per session, and you might find out now, like leukemia, the one which you're concentrating on today, the patient might have to receive like 8 to 12 sessions of radiotherapy. So for each session, it gets to cost 3,600. So as you can see, the cost is there, but we have the National Hospital Insurance Fund, which can be able to cater for this. So that's why we keep on encouraging the public to take up National Hospital Insurance Fund. Yeah.
And soon, October 1st, it will change to SHIF.
Exactly, it will change to that.
The same issue, Dr. Napo, you can see some of the figures that Celine is mentioning here, 280,000.
Yes.
To Kenyans out there, that's a lot of money.
Yes.
So are there other alternatives that these parents can use to ensure, aside from the medical insurance, if they do not have funds, where do they go?
Come to our hospitals. You will not be denied treatment because you don't have cost. As long as you're in the hospital, treatment continues, as long as it is available in the hospital. When it comes to the time where the child is discharged home, we have social workers who work in conjunction with the family, and you're able to be credited or waived off some of the charges, but you also have to commit on some. So treatment will not stop just because you don't have the money at that very time. Yeah, as long as you're in a public hospital, treatment continues. Yeah.
Thank you for that. That is very vital, given that they're watching you right now. They're looking for solutions. Dr. Bernice, now coming to you. As a country, we have witnessed in the past many people opting to go outside the country. Do we have enough facilities aside from the Kenyatta National Hospital to cater for the treatment of these children?
We do. The short answer is yes, we do. Yeah.
And elongate that answer now.
So,
are they adequately resourced? Do they have the capacity to deal with such cases in the country?
Okay. So we have both public facilities as well as private facilities that are catering to these needs for the children who are now affected with childhood cancer, right? So the costs obviously vary. 280,000 is in a national referral hospital, but if you go to a private hospital, it's probably going to be closer to the millions. So all that is dependent on again, your pocket. But I know that also private insurance will cover some cost. Even NHIF will still cover in private institutions, but there's a cap to it. Etc. So in terms of availability of care for these patients, there is availability of care in multiple hospitals across the country. Yeah.
And in terms of awareness, given that you even having that particular webinar, are you also addressing this issue of patients going to seek treatment in India and other parts of the country?
Yes, we are. We are.
And of course, in that particular webinar as well, talking about the cancer treatments that have been factored in, are you looking possibly at other alternatives aside from surgery, chemo and radiation? Are there other alternatives are you exploring in terms of treatment of cancer that have maybe come up within the sector and you're just trying to test it out?
At the moment, yes, we usually call them like clinical trials, which are ongoing, and we also have other new novel treatments known as immunotherapies, which are actually, yes, they are available but quite expensive, but they really have good outcomes. So the immunotherapies, also known as biotherapies, are available, but for specific cancers. Yes.
And Dr. Napo, we're talking about support, because I'm sure if a cancer treatment, when it comes to treatment of such cases, it requires not just huge finances, but the support. Are you getting enough support from the government?
Yes, we are. The government, most of the medications that we need are being supplied in our hospitals. Yeah, so unless there's just a supply issue, but most of the treatment that we need is available in our hospital. Yes.
And have they addressed some of the challenges that you're experiencing, especially as an institution in catering for these children?
Yes, yes. Matters cost and availability has been addressed. largely we can say more than 90% of the medications that we need, be it even the supportive medication. We are getting a lot of support from the government for our institution. The product support, be it the blood and blood product support, is also available in our institution, which also I'll credit it to our government. With the new oncoming treatments also are available in our hospital. Yeah.
And Dr. Benny, still on the same, we have witnessed even this current administration talking about once the social health insurance fund is in place by October 1st, they'll be factoring in this cancer treatment. So what do you like to see being addressed in the new insurance that was not addressed in NHIF, given that you've just said in the private hospital there is a cap to the treatment that you're receiving?
Yeah. Well, that's a heavy question.
Yes.
Because as it stands right now, they are covering chemotherapy, they are covering bed charges, they are covering diagnostic imaging and surgery as well. Yeah, so that's essentially also radiotherapy. So that's essentially the whole spectrum of care for children with cancer and malignancies. I think what we want is just a scale up, because there's more children to be taken care of. There's more people who are outside of NHIF/SHA in the near future. So I think it's just also creating that awareness amongst the populace that it's important to register for this service, because it really benefits you in the long run, not just for cancer, but also for other illnesses. Closer to home. Then just in addition to what Dr. Napo was talking about in terms of transfusion and everything, and linking that to the question you asked about myths, I think blood donation generally in the African context is still very mythical. There's
blood
a lot of
donation.
Yes, blood donation, because these children need a lot of support in terms of blood products and blood itself. But in terms of us as a people, culturally, we don't really donate, naturally. If somebody has to be sick and then you're told, oh, we need blood, so you galvanize your relatives and your friends and you try and get as much blood as you can. But generally, we need to move to a point where we have a culture of blood donation, especially amongst young, healthy males, because they have the least complications in terms of screening. We are exposed to different blood types because of multiple pregnancies. So it's a longer screening process, just to put it basically, but especially amongst men, I think also you have more blood. We lose blood every month. We lose blood through pregnancy. So I'm just saying, generally, blood donation is something that we need to scale up as a nation and to see as something normal and not taboo. Or if I have somebody else's blood in my system, am I me or am I them? You're still yourself. So I think we also need to build that service nationally and regionally.
And we've witnessed even the Kenyatta National Hospital carrying out such drives. So are they still on there? And are people coming out?
Yes, they are. They're actually coming out in numbers, and we really appreciate that. But we need more, because you see, blood is a product which cannot be produced, in a lab or in a factory. It actually has to come from someone. So the doctor is saying that we really need to bring it up and just take it up, just to be able to donate as much as we can, because blood saves lives, and especially for our cancer patients, they're receiving blood like in a week, just a week. A patient, one child has received, like several transfusions, probably even like every single day. So we really need them to, our public, to come in and donate as much.
And Dr. Napo, we have seen people focusing on cities, Nairobi, Mombasa, Eldoret. What happens to the people who are in Baringo, Turkana, who do not know some of these issues? Are we creating awareness even down there?
Yes, we are, starting from the healthcare providers a lot, and especially Kesho has really been working a lot with the healthcare workers. Every week we have different trainings through the CMEs, which are continued medical educations. So we are creating awareness to start with the healthcare providers as we go down to the communities, because the healthcare providers we are training, we are sensitizing on all this early detection, early diagnosis, early treatment, are the same ones who are going to the communities in different arenas, in the churches, in the family areas, and they're the ones who are referring to us, to the main cities.
I'm sure, Dr. Benis, you have attended so many seminars, benchmarkings. Are we doing enough in terms of adequately supporting you people in the sector to ensure that you go to other countries and seeing what other countries are doing as opposed to our own, and what we can improve on?
Yeah, there are a lot of strides towards that. Even just me being here as a pediatric hematologist and oncologist is a product of that support, because somebody had to fund my education in that sense, make me a bit better for the children that we care for. Same as Celine, same as Dr. Napo. Right, so there is some support, and there's still a lot of strides being made in that area. There's a lot of training ongoing for both nurses, doctors, medical officers, etc. I think in terms of capacity building, we are moving in the right direction. Yes.
Do you have enough personnel in addressing such kind of cases, especially at the Kenyatta National Hospital?
I will definitely say yes. In fact, this being the Childhood Cancer Awareness Month, we have a workshop next week, and we've actually worked a lot with international partners who have really helped in capacity building, and they've actually ensured that we do have trainings in pediatric oncology for both the nurses and the doctors, and which are ongoing like every single week, every single month. We continue with that, and as you can see, as we are here, we're actually specialists in oncology. We were able to go to school, and we have different institutions who are also offering oncology care, oncology education. That is, we even have MTRH, which is actually now doing a high diploma in pediatric oncology. So all this is actually going all the way towards improving the quality of care, pediatric oncology, and capacity building.
Given that that seminar now is coming up, Dr. Napo, what are some of these issues that those seminars should be addressing and be improving on, so that at least at the end of the day there is not just affordable treatment, but a treatment that we can embrace as Kenyans?
The aim of these workshops is mainly to first train the current Kenyan healthcare workers to be able to look out for these early signs, early symptoms, and early referrals, especially from the different counties, because we don't just look at the healthcare providers in Nairobi. We invite across all government hospitals across the country. They all send representatives differently. This will be our third conference.
Yes.
So in the last 3 years, we've done quite a big training and it doesn't end there. We share contacts. Sorry.
Okay.
We do share contacts with our colleagues, and anytime there's a suspicion or a query, we always reach out to each other. And if it's a referral, we push for early and prompt referral to our main centers, be it for final diagnosis, completion, or early starting of treatment. So we all work together. So there's capacity building, there's improvement in quality of care.
And before we take that particular link, let me give an opportunity to you, Dr. Penis. Also, there's a conference in Kisumu coming up, if I'm not wrong, of Kesho.
There is.
Yes, and what will we be focusing on?
So every year, Kesho does host an international conference where it brings together stakeholders working in the hematology and oncology space. This is both adult and pediatric hematologists and oncologists, as well as international collaborators, be they people who deal with diagnostics, be they people who deal with actual treatment, research, etc. So it brings all of us together, and we're able to sort of compare notes and see what we can adapt or even adapt from, or what they can also adapt from us. Because as we said, there's a lot of work that goes into coming up with the treatment plans that our children use in this centers where we work. So, and most of that work, unfortunately, has not been done on our continent. So most of what we do is adapting international protocols, but we're also building our own work. And from our adaptations, we also have a bit of data, which we're using to also just show that this is how we are treating, for example, leukemia in Kenya, and these are the outcomes we're getting using these protocols. So it's a nice time for us to network and to learn, and also to continue growing the field and the practice. So in terms of who is invited, there's the medical practitioners, there's the nursing staff, and people who work directly with the children or other adults affected with malignancy. But there's also other relevant stakeholders, including insurance companies, etc., who can then be able to be advised on how to even design covers for people who are going through these diseases in terms of treatment and follow-up.
Hold that thought, ladies. I'm coming back in just a few. I want to take our viewers. I do understand that the Acting Inspector General, that is Masengeli, is currently addressing members of the Forum of Justice Mugambi. He clearly stated that he cannot talk about active court cases that are before the judges. And of course, we await to see what will happen, given that already a sentence was issued chaired by Justice Mugambi. Yesterday, the National Police Service issued a statement in regards to the withdrawal, or the alleged, of course, withdrawal of police officers from the detail of Justice Mugambi. We even saw the Chief Justice Martha Koome addressing the same concerns. We're waiting to see how that will unfold in our bulletin. But right now, we're speaking about leukemia in children. We have experts in the studio. They've been able to talk about the cost, the treatment, and other opportunities that are within to addressing these particular concerns, because the myth that surround this cancer treatment and cancer itself, given that even Dr. Bernice was talking earlier on about that the major myth that is associated with cancer is death. Now, going back to the various conferences that are going to be held here in the country, aside from the cost, the treatment, as well as other forms of cancer that are being experienced here in the country, what are these other issues, especially when it comes to policies, Celine, are you expecting to address there?
So in terms of policies, when it comes to childhood cancer care, the way we usually say, the way we're saying even today, that we need to create awareness, because unfortunately for cancer, for childhood cancer, you cannot be able to do screening, maybe for specific cancers like retinoblastoma. But now, since we cannot be able to do the screening, we need to create awareness. So in terms of policies, we need to still work with the government and other non-governmental organizations so that they can be able to support us in, yes, creating awareness, ensuring that there's availability of drugs, ensuring that, like now for the SHA, which is incoming, will be able to address the challenge of lack of the parents not being able to have the money which they require to be able to receive treatment. So in terms of policies, that's the one thing which we really need to drive at. And the good thing is that the NCI and the NCCP are actually working closely with the conference and the workshop in order to be able to create this awareness that yes, there is hope, and we can be able to work towards getting better outcomes in cancer care. Yeah.
And Dr. Napo, we know the ultimate goal, especially when it comes from the World Health Organization, the global initiative for #childhood care cancer aims to improve the outcomes for children with cancer around the world. And of course, by 2030, this initiative seeks to achieve at least 60% survival for children cancer globally, and reduce suffering for all, and saving at least 1 million additional lives. So where are we in terms of reaching this particular goal, and as a country, can we achieve it?
Good strides have been made. We don't have the accurate documentation and statistics collection for the current cases that we have, because they're subtly recorded in the different centers that we look after these children. So I've not come across the consolidated statistics for childhood cancer care and the survivorship, with the many challenges, be it in our follow-up and our loss to follow-up with our patients. So currently, but there are good strides being made. We're definitely better than where we were 5 years ago. Yeah.
And as you comment on that, Dr. Bernice, I can see also in your conference you've invited especially government officials. Have we done enough, especially to adequately resource researchers, because we know they are very vital in addressing some of these issues? And in terms of inviting those researchers, what are these areas are you likely to focus on?
Right, so we'll focus on like what you're saying, where we are as a country. Yes, there's still a lot of work that needs to go into research and building robust data registries. So I think the first thing is to create a sort of cohesive database, which is what I think the NCI is working towards, which is why you sourced your initial statistics.
Yes.
So there's the NCI which is working hard in terms of sort of marrying all the different sources of data and giving us one rich database that can be used to generate national statistics and other subsets of data. So there's that. In terms of government and non-governmental officials or partners or collaborators, again, it's just it's a goodwill. We have a lot of policies in place in regard to cancer in general, and we also have a few ones in regards to childhood cancer, but we need that political goodwill. We need that person in the office to be able to now push towards implementation of these policies, because they are good policies and they can push us to where we need to be so as to meet the WHO goal of up to 60% survival in those key index malignancies that have been here.
And Celine, the other question that arises is, do we have enough medication in the country? Do we manufacture here, or do we import them?
That's a good question. So I would say that the drugs are available, but the challenges come in supplies, and we actually get to receive these drugs from other countries, from outside. So they are available, but now the challenge sometimes comes in the supplies. So that is why when we were talking about the global initiative of for childhood cancer, we have the Cure All framework, which we can only be able to attain it because now this is a framework to be able to support the government in leadership and in technical support, in technical assistance, that is, so that we can be able to ensure that eventually that childhood cancer drugs and the essential drugs are actually free for our children, and that is what we need, the political goodwill. We already have the support because actually Kenya is among the first 6 countries which have been identified for the global initiative for childhood cancer by the WHO. And so through this framework, we can be able to eventually get to that so that the drugs can be available and they can be free through this support.
And Dr. Napo, what are some of these emerging trends that you have been able to witness, especially when it comes to cancer treatment and ensuring that they are prevented at an early stage compared to other countries in the world? Are we keeping up with them or we are lagging behind?
For the trends, I think we're still a bit behind, but we've really introduced a lot of the diagnostic and specification of diagnostic innovations in our country, even in our public hospitals. With for example, for leukemia, we have the general diagnosis, which can be done on a peripheral blood or a bone marrow sample, but also that is via looking at the sample via microscope. But also we have the immunophenotyping investigations that are even available at Kenyatta National Hospital now. So we are moving somewhere. We have the immunos even for our solid tumors. Strides are made, but we're still a bit behind.
Given that we're still behind, Dr. Badis, we're talking about some of the benefits. As much as we are citing some of the challenges, what are some of these benefits we have been able to witness in the country that has brought us this far?
So one is the availability of the drugs, of at least the essential drugs you need to manage majority of the childhood cancers. So we've come a long way from where we were even just 5-10 years ago. And this has also shown in terms of the outcomes we're now seeing with our children. We do have improved treatment protocols, which means that there are adjusted doses, there are different molecules being incorporated to these treatment protocols, and with that we have seen an improvement in the outcomes for these children who are affected. Another thing is diagnostics. As Dr. Napo has said, we have come a long way from simple x-rays and ultrasounds to MRIs, PET scans, and now even immunophenotyping, which is a far cry from where we were just a few years ago. So we are moving in the right direction. We just need to continue supporting each other and even our supporters so that we can continue to grow and again meet this WHO target of at least 60% survival, especially for the indexed malignancies.
Other benefits we have witnessed, especially from the Kenyatta National Hospital?
Especially from the Kenyatta National Hospital. So from what I can be able to see, we have quite a number of patients who have actually been able to complete treatment. The treatment have been available, and because they're really working towards ensuring that the drugs are available, throughout. So we actually do have a number of patients who have who are actually survivors. Last week we were celebrating the opening of the Kenyatta University Teaching and Referral Hospital, opening of the oncology ward, and we were actually able to celebrate some 2 survivors. So actually making a lot of strides. We're also having child life specialists who are working closely with the children. That is actually a really, really big development, because long ago, we used to be just thinking that, care for cancer is just, the chemotherapy, radiotherapy, and surgery. But just as Dr. had said, we need to look at the patient holistically. So we have the child life specialist program. We also have the patient navigation program, whereby we're working with the patient and the parent, because the parent is the one who's going to be staying with the child. So they need support throughout the time, and through this patient navigation program, we're able to address any gaps which the child or the parent or the family is going through, and be able to see how we can be able to bridge that. So from my point of view, I can be able to see that.
And of course, Dr. Knapp, we're talking about psychosocial support, especially for parents who are dealing and the caregivers who are handling these particular children. So have we done enough to ensure that they receive psychosocial support so that at the end of the day they do not give up easily, because giving up is so easily?
Yes. In our institution, we have a lot of psychosocial support, be it from the religious leaders to our trained healthcare providers. Our social workers are there. We even organize for family, the extended family, to come, and we work with them, we introduce to them what is happening, what is expected. And in the journey of the patient, we work with the whole family, not just the parent, not just the immediate siblings. We work with them. There's a lot of support, be it in the other siblings that are at home. We look at the whole family centered, even in matters cost and the other supportive care that they need within the hospital. They're able to be given. We have the palliative care unit, we have the counselors who both counsel the parents, the extended family, and the patients who are of age to understand what is happening to them.
And this cohort, Dr. Bernice, we cannot forget. There are people who believe, aside from this conventional medicine, there are those people who believe in herbal medicine. So how do you handle such cases?
Well, so it gets interesting because yes, it's quite prevalent in our region, actually, to have alternative medicine in the form of herbs and leaves, etc. So it's very difficult to sort of quantify what molecules or what chemicals are present in any herbal concoction. So it's if a patient's family were to choose to go the herbal way, then we would have to respectfully step aside and allow it, but not mix it with chemotherapy, for example. We can't do both. See, chemotherapy is manufactured, it's measured, it's dosed and everything. I cannot speak for the herbal concoctions. So we discourage the use of both. And if a family insists, we do not force people to get treatment. We encourage it, but we do not force it.
Does this boil down, Celine, to trust, especially from caregivers and the doctors who are there and the specialists who are there? So how do you ensure that you boost that trust so that at the end of the day they can believe in some of the conventional treatments that we have in the 21st century?
I think I would say constant communication and ensuring that we get to involve the parents, just as Dr. Knapp said, through the psychosocial care, through the consistent counseling, because with this information, the parent is able to make a better decision, just like in any other setup. So consistently, we usually do counseling like every other single day, so that we can be able to inform them the benefits of chemotherapy and ensuring that they stick to the treatment. Because yes, we also do have the loss to follow up, and that's when they get to when we have the loss to follow up, they get to end up to go back home. They get to get into the traditional herbal medicine. Then they get to come back when they're in the metastasis has actually, it has spread throughout the whole body. We're now in 4th stage or even end stage. Now we are offering more of end-of-life care, all because they did not have that information. So we usually do the consistent counseling, consistent psychosocial care, so that they can be able to know that they are stakeholders in the care of this child. And with this information, they can be able to make better choices towards care.
And of course, with such cases, what do you tell parents? I know some of them are hard-headed, they do not want to listen, but how do you approach such cases? I'm sure you have at least interacted with one or two.
Yes. We talk to them from what we know. We explain to them the reason and the importance to first seek the medical care. We actually take it as we were telling them, give us a chance, let's do this. Let's first witness the experience and the outcomes of the medical care, but we cannot mix. We also call in parents. We have the patient support groups. We call parents who've tried the other way, the alternative medicine, and they've come back with regrets. So we call the parents to also encourage the new parents. So it's more of us giving the care and the support to the patients, the new patients, but also a lot of patients, because this is a chronic thing. You've stayed with patients for months, years. So for the older or the more patients who've been there longer are able to encourage the new patients on, don't try that side. we've been there, it didn't work well, stick to their side. And the patients actually, when they see the improvement and the good outcomes from their patients, they will never go the alternate way. Yeah.
It also helps to address the stigma that's associated with the diagnosis of cancer, because they're all getting treatment together and they're seeing good outcomes, and people are living beyond the cancer. So these are the ones who now become our advocates out there in the community, and they push people to, you know, seek medical attention. Yes. So that advert was playing in my head.
Thank you so much. And of course, as we are winding up, let me start with you, Celine. Your final remarks, and what can we look forward to, especially for the upcoming conference?
Thank you so much. So my final remarks will be, let us continue creating awareness. Let us create hope towards childhood cancer, because with early diagnosis, we definitely expect there will be early treatment and better outcomes, and to be able to offer the best quality of care for these patients. And towards the conference which is upcoming, we expect the good thing is that we've been doing a lot of research even here in Kenya, so we'll be showcasing the research which we've been doing, the novel technologies which we've been able to experience, so that we can be able to improve our patient outcomes. Because if we do expect to get to a 60% survival rate, then we need all the stakeholders to come into place so they can be able to work together towards that. So there is still hope in childhood cancer, and we can be able to get to where the high-income countries are. Thank you.
Dr. Napo?
Yes. My final remarks will be to the common wananchi. Cancer is treatable within Kenya. Cancer is treatable. We have so many unsung heroes, so many survivors from our childhood cancers who are out there the normal life. If a child is not well, seek medical attention. No doors are locked up to you. Come, we'll treat you. Thank you.
Doctor?
I think mine is just to fortify the same message, that early detection is our best hope at getting good outcomes in children. So whenever you feel a child is off for whatever reason, you'd rather come to the hospital and be told that nothing is wrong than ignore it and wait for it to fester and now present to us with advanced disease. So I think we just need to improve our health-seeking behavior. Don't be afraid of hospitals or doctors and nurses. Yeah, we are here to serve. We're here to help. Yeah, so if you notice anything, just come.
And the conference at Kisumu?
Yes. So keep forgetting that bit. So Kesho, the Kenya Society for Hematology and Oncology will be hosting its annual international conference this year in November in Kisumu, where we'll be addressing all these diseases that we deal with on the daily, as well as showcasing research, both local and international. And hopefully by the end of it all, we'll be able to continue improving even the care that we're able to give these children within our borders. Yes.
Thank you so much. That is Dr. Bediz Mukuria, a pediatric hematologist, a member of KESHO. Thank you for making time for us this morning.
Thank you.
As well as Dr. Napo Mugoma, an oncology medical officer at the Kenyatta National Hospital. Thank you, Daktari, for coming in. And finally, we do have Celine Kilanya, a pediatric oncology specialist nurse at the Kenyatta National Hospital. Thank you for informing us on what strides we're making as a country, especially when it comes to treatment, not just in leukemia in children, but of course the adults as well, given that there are cases of adults who are experiencing or undergoing such incidences of cancer, as well as treatments, and the strides that we have made as a country in regards to that particular sector. Of course, with the oncoming of the Social Health Insurance Fund, the Ministry of Health assured that cancer treatment will be addressed there as well, so that you don't have to go outside the country to receive some of the treatment. You've just heard from the experts. We do have the facility, we do have the resources to cater for such incidences. That marks the end of our conversation this morning. But coming up next is Kasichana Masha with Kurunzi Mashinani, and of course in other stories that are making headlines across the country in regards to also what the acting IG has just told members of the Fourth Estate, and various parliamentary proceedings that are happening given that Parliament resumes today. My name is Abdiaziz Hashim. The sign language interpreter at the bottom end of the screen is Susan Thuku. Good morning for now.